Let's take a look at the BIHCA trial, which compared Bicarb to placebo for in-hospital cardiac arrest. The BIHCA trial included 779 patients with in-hospital cardiac arrest and randomized patients to receive up to 2 doses of Bicarb with the first and second doses of epi. This trial was definitely necessary considering the state of Bicarb use. Sodium Bicarb is given in about half of in-hospital cardiac arrest despite recommendations against routine use, and it's becoming more popular over time. Adult patients with in-hospital cardiac arrest that received 1 dose of epi were included. The most interesting exclusion here was clinical indications for Bicarb, defined in the supplement as hyperkalemia or tox indications, specifically TCA overdoses. The primary outcome was sustained ROSC, defined as 20 minutes of sustained pulses after getting ROSC. Key secondary outcomes were survival at 30 days and survival plus good neurologic outcomes, defined as an MRS of 0 to 3 in that same time period. The majority of patients coded on non-ICU floors and had non-shockable rhythms. Time to administration feels on the slow side, 5 minutes to the first epi and 8 minutes to the first study drug administration. Notable deviation from protocol was a small number of patients not receiving a second dose of study drug, 8% and 5% in the Bicarb and placebo groups respectively. Bicarb was also given on the side at a low rate, 6% in the Bicarb group and 7% in the placebo group. Notable, but considering the small numbers, a little less likely to influence the outcome. There was no difference in sustained ROSC. Survival or survival with good neurologic outcomes were also not different at 30 or 90 days. The discussion highlights the state of the data prior to the trial, all out-of-hospital cardiac arrest data. 2 of the trials are over 30 years old, but the more recent trial is one that I cite frequently. This pilot study from Anna and colleagues randomized 50 patients that had not achieved ROSC after 10 minutes of CPR in the ED and a confirmed acidosis on ABG, defined as a pH less than 7.1 or Bicarb less than 10, to receive either Bicarb or placebo. This leveled out to Bicarb administration after about 31 minutes, as opposed to 8 minutes in the BIHCA trial. While Bicarb administration made the numbers look nicer, improving both pH and Bicarb levels, there was no difference in ROSC or good neurologic outcome, turning worse in the Bicarb group. While it was powered to detect a difference in ROSC, the authors state it's unlikely that there's a difference in the more patient-focused secondary outcomes considering the narrow CI for sustained ROSC already. They also state it's not feasible to get labs during an arrest, despite citing a trial that did just that 2 pages ago. Considering most of the codes were on a floor and not the ED, probably fair enough. Despite getting Bicarb in faster, there was no improvement in outcomes in BIHCA. But what do you think? Is the lack of harm for Bicarb going to prevent this trial from being the smoking gun that cocoa was for calcium? Or is it time to shut down Bicarb use outside of hyper-K or tox codes? Check out the link studies in the description and decide for yourself.